Dr. Bhattacharya, welcome to the show.
Oh, thank you.
So it's great to have you. A lot of people know about you, but what I personally don't know much about is what you did before COVID. So I thought maybe we'd start there and tell us what you did professionally, obviously, what kind of research you were involved in, where you were publishing, that sort of thing.
Sure. So I have a little bit of a strange professional track. I have an MD and a PhD in economics. I have sort of stumbled on it. I mean, I always wanted to be a doctor, discovered economics, and I realized that that it actually has a lot to say about in medicine. Like medicine is full of trade-offs. Economics is the science of trade-offs, and it turns out it has a lot of these tools, these epidemiological tools, statistical tools you get trained in. So I sort of ended up in that space. I mean, by accident, more or less. Before COVID, I worked on a whole bunch of things. I think like the most prominent set of things that I worked on the economics of obesity. Actually, it's in some ways very similar, right? One of the questions I was interested in is whether someone who's obese, do they impose cost on others, and does that warrant public health action? It turns out that it's much more complicated than that. I mean, like we've actually faced the same kind of questions in context of COVID. Like do my actions affect you? Does that impose that? What does that mean for the right actions the government might impose on me because I might affect you by my actions? I've worked on measuring quality of care provided by doctors. I've in fact worked with CMS to help develop some of these measures for physician quality. I've worked on a ton of infectious disease work, going back to the HIV days. One of my very first papers on HIV. I've also worked on H1N1, including some of these these SIR models in 2000. Actually, one of the way I sort of got involved with COVID was from my H1N1 work. I noticed in the early days of that H1N1 that there was people were putting out these estimates of mortality rates, these case fatality rates that were incredibly high, 4, 5, 6%. And then I didn't work on this back then, but I followed the literature of these seroprevalence studies back then, and it turned out that there was 100 times more infections than cases in H1N1. Mm-hmm. And so the infection fatality rate turned out to be 100 times less. I mean, it was like 0.1%, 0.01% more like rather than 1 or 2 or 3%.
Right. So just to be clear for the audience, you conducted seroprevalence studies for H1N1, found out that many people had been infected, had the antibodies, but either were very minimally symptomatic or not symptomatic at all.
So in H1N1, I was much more interested in whether perceptions of risk of the disease change people's behavior, whether the sort of self-lockdown.
Okay, right.
But because I was involved in the literature, I tracked the seroprevalence studies. So the very first thought I had when I saw the World Health Organization say there was a 3% mortality rate, where they didn't say what they were saying, but they were saying case fatality rate. Mm-hmm. My very first thought I had was, well, what if this disease is much more widespread, just like it was with H1N1? It's a respiratory disease. It's supposedly incredibly infectious. We don't have great testing resources. Surely many more people have been infected. So that means the death rate, the infection fatality rate is going to be way lower than the 3% case fatality rate that was being reported.
Right. Okay. Well, that's very interesting. And again, your work, you have a team, you raise grants, you apply for grants, that sort of thing. I mean, is it?
Yeah, almost all of my work has been funded either by the NIH, the FDA, or CMS, Center for Medicare and Medicaid Services. I work with a company called Acumen LLC. We do contracting primarily with CMS and FDA. And so, in fact, with the FDA for the last decade, I've worked on biologic safety. Some vaccine safety work, mm-hmm. But almost all of my work has been NIH funded primarily.
Okay, great. So COVID comes around, and so it's great because that was my next question. So you immediately start to have this not a concern, but this obvious thought, and you weren't the only one. I mean, I think John Ioannidis also had the sort of a similar reaction, try to understand, how prevalent is this, and you conduct a study, I think a first study, You want to tell us a little bit about it? I think I want to quickly move to the Great Barrington Declaration.
Sure.
But nevertheless, I think this is important to.
Yeah, absolutely. So in fact, I worked with John on the study. The Santa Clara Serum Problem study, we did a survey of antibody prevalence in the population of Santa Clara County. That generated a ton of controversy, actually. But the results have been replicated over and over again. So the basic, in fact, I myself replicated them in LA County in April of 2020. Santa Clara County, same result. So we found in Santa Clara I think it was like 2.8% prevalence, which sounds low, but in fact was 50 times more infections than cases that had been found up to that time. Means the infection fatality rate was 0.2%, not 3%. It wasn't 0.01%, 0.01% like it was H1N1. I mean, this definitely way more deadly than H1N1. But then, or the swine flu from 2009. But then in same result in LA County. There was 4% prevalence, the 40 times more infections than cases in April of 2020. Infection fatality rate of 0.2% again. And John Ioannidis has been tracking these infection fatality rate, the seroprevalence estimates are all around the world. Turns out the Santa Clara study was dead smack in the middle from the seroprevalence studies in 2020. In 0.2% global median infection fatality rate, with this huge age gradient where older people have a much higher fatality rate than younger people.
So it's remarkable. I mean, I remember vividly the outrage that it generated from the get-go, with people immediately looking to, finding flaws in, the way the study was conducted, but I mean, any empirical study, especially at the beginning of an epidemic, I mean, it's going to have some flaws. I mean, right? I mean, you're going to have some limitations.
I think there were a couple of a couple of things that we did. I think we rushed to release a preprint of the study because we just felt responsible. Like we had a result that was an enormously important result, we thought, for policy. And in doing that, the first version of the preprint, there was an error in one of the standard error calculations. And so, I got within like 2 seconds of releasing the study on medRxiv, we got 1,000 peer reviews. And I'm not exaggerating, 1,000 people writing to me on email or like trying to contact friends of mine. It was like, oh, you did this wrong. I mean, first it was humbling to have a study that generates so much attention so quickly. And the study, so within a week, we released a revised version of the study that corrected that error. But in the meantime, we got a lot of people that provided us other data that was really important for the study. So for instance, we used a test kit that for the antibody test kit that we had the manufacturer's word for how accurate it was. But by releasing that study early, we got many people giving us additional positive and negative control results for that test kit, which allowed us to get an even more accurate estimate of that thing. In any case, it was, as you say, it was an early study. It was an early study. It was going to result in that's why the preprint process is there. But it's been replicated hundreds of times now. So I think the reason why it was so controversial was that it was so unexpected for many people. 2.8% of the population is not a large fraction. That means the disease obviously had a very long way to go, but it was sufficiently a high fraction that the strategy that everyone had adopted, which is this test and trace strategy, that was the preferred strategy. Why aren't we testing more? We should test more. We should test and isolate and trace. That strategy could not work. If 2.8% of the population have already been infected, or 4% of the population have already been infected, it's too late for a test and trace policy to eradicate the disease. I think that implication was at the root part of why it generated such controversy.
But don't you think there was also a sentiment, perhaps, and maybe we'll talk about it later, of saying, how dare you insinuate that this disease is less deadly than we think it is?
Yeah, I mean, we had just done something absolutely extraordinary. Where, like public health had adopted this lockdown, this quarantine order for a very large fraction of the population. A healthy quarantine, I think, has at population scale, I don't think has ever been done before. And we had to justify it. If this is not a 3%
Mhm.
Fatal disease, but in fact, only a 0.2% fatal disease. Well, I mean, the costs, the harms of that are enormous. And we've seen the harms. We can talk about that when we talk about the Great Barrington Declaration, but the harms of the lockdown are devastating, orders of magnitude worse than whatever marginal benefit you may think we may have gotten from it. So I think that certainly played a role in, like, people were justifying their support for this policy, this absolutely extraordinary policy, by the idea that this was a uniquely deadly disease. And so if it's 0.2% and not 3%, well, I mean, we made a mistake, and a lot of very smart people making a mistake is not, that it's hard to make. I mean, people don't want to really admit that they got something so catastrophically wrong.
Right. So, you're castigated, for these little mistakes and whatnot. People say, it can be true. It's flaws in the, but within, I mean, it didn't take long. I think within a month or two, there were many other studies that sort of confirmed, as you said.
Well, it's just I want to, preparation, I've been reading a bunch about what you've commented on the Santa Clara study, and I was impressed in an interview that you did with Ovik Roy for FreeOp. This is in 2020 sometime. And you did a fair amount of work. You already told us a little bit about what you did in response very quickly. But I just want people to just get a sense of even in the planning of the study, this wasn't some not well thought out study. For instance, one of the criticisms that was leveled at you was the demographics that you polled, right, and how you went about soliciting patients for the study. As I recall, Facebook ads were used and whatnot, and so that would then give you a demographic that's different in terms of what the what your estimates are. But it's not that you didn't think about that, right? I mean, what did you do, given how this study, the demographics were, and what you did to try to weight it for the population that you were,
Yeah, I mean, that's a really good point. So we wanted to get a sample as quickly as we possibly could. The study was organized essentially in 2 weeks. Normally, this is the kind of study you would take a year to organize. You'd get a sampling scheme that would be population representative. What we did instead was we recruited on Facebook for people who wanted to sign up for the study. The problem with Facebook is that it tilts toward high income demographics. And in fact, that's exactly what we got. In fact, a large number of Stanford colleagues of mine wrote to me wanting to be part of the study because they wanted to know their antibody status. I had to say no because there wasn't part of the sampling scheme, right? We ended up with a large number of people right around Palo Alto, like just rich parts of Santa Clara County. And as we know, that actually richer parts, the lockdowns actually protected the richer parts. So we needed to reweight. So the ultimate result was 50 positives out of 3,000. But once you do the reweighting, so that we don't oversample people that are younger, that are richer, so that you get a more equal distribution, yet ends up with that 2.8%. It's funny because like we did the study in LA County with a very different sampling scheme. We actually hired a professional firm that does like, I think like, they do representative sampling for a living. And we actually ended up with a higher prevalence in LA County than we did in Santa Clara County, even without the weighting. The other criticism was leveled at us was we ignored the false positive rate and false negative rate of the test kit, but that's just wrong. I mean, they just didn't read the paper. We had a formula to adjust for it. The problem was like the standard error calculation of that involves not just the standard error from the sampling of the test kit of the survey, but also of the test kit. You have a false positive rate. For that, you need to check. You need a whole bunch of negative control samples. You have a false negative rate. For that, you need a whole bunch of positive control samples. And so you need to take the sampling error for all three. And that was where the error was made in the first version, corrected in the second version.
Right. And again, I mean, by nature, all these population prevalence studies are going to have scheme. The schemes are all flawed. I mean, there's no perfect scheme. I mean, it's very, very difficult to get what does it even mean? A representative sample
I
of
mean,
the
it's the thing
population.
is like what was really hard was, your people are staying at home because it's a stay-at-home order in place. You can't go sample a grocery store because they're not a representative sample. I mean, a lot of places did that. A lot of studies did that. It's a very difficult challenge in the midst of a pandemic to get a
Right.
representative sample.
Right.
I mean, I think we did the best we could. Is it perfect? I mean, absolutely not. Like, that's why I think you wait to get to see the result of all these other studies. I mean, like, it was actually quite good. It felt really good to see these other studies come out, one after the other, finding effectively the same result. Orders of magnitude more people infected and that changed a little bit over time. Like, as the testing resources grew, expanded, the multiplier of infected people to the cases went down. So it's like, I think now it's probably on the order of like 3 to 1 in the United States, probably. But back then, 40 to 1 is not an unreasonable result.
One of the criticisms that you encountered was, I guess the major one. One is the demographic one. The other one is what you've touched on in terms of the test characteristics and the fact that the bounds of the test of how well the test performs means that includes 0, right? So
like there was someone, I forget who it was, wrote this very nice Substack piece where he talked about, well, there's still a significant possibility that all 50 of the positives were false positives.
Right.
I mean, it turns out that's not. I mean, that's very, very incomplete. I mean, it's possible, very, very unlikely. But on the other hand, there was also false negatives you have to take into account. And so there's a formula which I read. Apparently, it's an old known formula, but I happen to rederive it for this. It turns out that when you account for both the false positives and the false negatives, you end up with the number we reported. The 2.8, and you do the reweighting. As I said, like, we did this study in LA County, which received almost no attention. It was published in JAMA. I don't know why it got so much less attention than Santa Clara, but we had a professional firm with the sampling scheme, so we didn't have the Facebook problem. The same test kit with the same correction, and it was peer reviewed and almost instantly. It was a strange time to be doing science, I think.
Yeah, I mean, right. And some of the criticisms were just beyond bizarre, right? I think I saw
personal.
somewhere.
I mean, it was like I never had a personal attack on me before April of 2020. It was such an odd thing, and now I'm used to it, of course. But that's another.
Right. Because so we know that what didn't happen after other studies, not just yours but others, corroborated this recalibration of how severe the epidemic was. What didn't happen is that people said, okay, we made a mistake. These major drastic lockdowns were wrong. So instead, the tenor of the public health approach sort of continued in a certain way. And then what happened for you? What was the next step?
Well, I mean, it was actually stunning to me. I actually thought that that once people saw that the infection was so widespread, they would change their policy. People would decide to, like, they should have realized that that the policy that we were following, this test, trace, isolate, that essentially population-wide protection was an impossible policy. I mean, I think they had in the back of their heads zero COVID. They looked at China, saw, oh, well, look, they somehow suppressed the disease to 0. We can do that too if we just lock down hard enough. And because I think the Santa Clara study should have killed that. The LA County, the zero prevalence study should have killed that. It was too widespread a disease to have any. And you can point to like New Zealand and Australia, but the disease hit in their summer. It was an island isolated. They actually could potentially get closer to 0. Obviously, that's failed now in retrospect, but like at the time, maybe that might have been reasonable to think. But everywhere else around the world, in Europe and the Americas, that was not possible to get to 0. And we should have realized that in April and May 2020.
Okay.
So that's the way I was thinking about it then. And I was, I'd started to think about alternative strategies. In fact, and that resulted in the Great Barrington Declaration, this idea that you have this age gradient in risk. Older people are of such high risk from this disease, whereas young people face so little. I mean, thank God, right? If children were the primary people affected by this disease, it would be, I mean, I don't know, I might have actually supported lockdowns. So I think the fact that you have this age gradient where you can adopt policies to protect older people while letting younger people essentially go on with their lives why would you want to let younger people go on with their lives? Because the lockdowns are devastating to them. In California, we kept schools closed for a year and a half. Public schools, private school kids, of course, could go, right? So it's one of these things where, like, in order to protect the old, we decided the only way to protect them was lockdown. And that was just a failure of imagination as far as I'm concerned. Like, there are policies we could have adopted to protect the old better before the vaccines. And we didn't do that because we assumed the lockdown would protect it. In fact, what happened was the lockdowns did not protect the old. So many old people die. 80% of deaths are 65 and up. And essentially, we adopted a policy that protected a class of people that are relatively well, the laptop class, right? That didn't lose their jobs at the expense of poor people and old people around the world.
Right, but couldn't the other side make the argument that had they not been, I mean, that, right, the alternative scenario could have been even worse, that in fact, the lockdowns did have some success, that, right? I mean, you could see that there was success, and that, you never know. I mean, it is, they could always say that, I mean, they would paint your alternative strategy as essentially letting it burn through, because they might claim, perhaps plausibly, that it's really hard to actually isolate the elderly from the young to some extent, without sort of because families live together and so forth and whatnot. So I mean, if I imagine myself being a layperson, or even as a physician, there's always a grain, at least a grain of plausibility in the doomsday scenario. Once they have a leg up, once they've imposed the lockdowns, right? And once you're in that scenario, then you do your research, but you do your research under lockdown situation, and you don't know what could have happened if you didn't have the lockdowns. Now, I understand that the infection fatality rate is a very important component of that, but nevertheless, you always think maybe the infection fatality rate is less, perhaps, because, I mean, in theory, it shouldn't matter whether you're under lockdown or not, but nevertheless, there's always that sense that it's, possibly could be worse. I mean, and I suspect in the publics and people who are less, knowledgeable about these nuances, one could think that it's just essentially a matter of opinion, right? I mean, it's not a scientific position, but it's just a matter of opinion. Some epidemiologists think that it's going to be doomsday, and others think it's not that bad. And at the end of the day, we don't know.
I think the empirical basis for the idea that lockdowns could work was extremely thin, Michelle, at the beginning, right? We've never tried such a strategy before. The main basis for it were essentially models like had these models like the Imperial College model.
Right? Mm-hmm.
Yeah, and built into that is an assumption that lockdowns will work, because the way these models work, these compartment models, this is something I actually worked on at the H1N1. You have essentially people interacting with each other. It's a series of differential equations, but this is the idea of the model. You have a series of differential equations where people interact with each other. And when they interact with each other, if a infected individual interacts with a susceptible individual, they pass the disease on at some rate. Right. So you have this built into the structure of the model itself, the idea that if I separate people, I'm going to reduce the spread of the disease, right? So you have this. So it's a very, very odd situation. But that's not evidence that it's going to work. That's an assumption that it's going to work. Presented if it were evidence it was going to work. That's the problem we had there, right? So you have a situation where you didn't have evidence it was going to work. Now we actually now have real world evidence. We have a lot of real world evidence. So like I did a paper with John Ioannidis and Eran Ben David in January of this past year, where we looked at the lockdowns in Europe, various countries in Europe, and we compared them against Sweden and South Korea, which did not impose mandatory stay-at-home orders, didn't impose mandatory business closures. And there's no evidence that we can see that the lockdowns actually slow the spread of the cases. when you do that sort of A/B test, at least in the early days of the epidemic. I mean, I do think that the lockdowns protected a certain class of people. I mean, that's pretty clear. If you look, for instance, in places like LA County, where the rich neighborhoods, you have way fewer cases per versus the sort of poorer parts of LA County. But I think that that's at best what lockdowns can do. If you actually can hide, if you can afford to hide from other humans, yeah, you can protect yourself. The problem, it's always been the problem with lockdowns, most people cannot do that. And we assume that they could. And in fact, worse, we shamed people for not being able to, stay at home without, because they had to feed their families. Right. I think that essentially we had this action bias. We have to do something. And the class of people that were in charge of the policies thought to themselves, well, I can stay at home. Well, can't everybody else? It was a huge failure of imagination. And as I said, it didn't actually end up protecting the old. The idea that like something like the Great Barrington Declaration, right? You have this 1,000-fold difference. Let's protect the old. That was the idea, that focused protection, that it's impossible, is a failure of imagination on part of public health.
Would you say that? Oh, sorry, I don't mean to cut you off.
Please go ahead.
Would you say that Florida, which under Governor DeSantis really took your advice early and was one of the few state, they had a roundtable, I remember, with you and Dr. Kuldorf that apparently was too hot for YouTube even. But when you see how Florida has done, especially with the summer wave that many of us hoped that would not happen, I have two questions. One, were you surprised by the summer wave? And two, now that, in what are we in, September, fall of 2021, how would you grade how Florida has done in terms of, say, Florida is widely viewed as following the Great Barrington, following you folks, not following, Fauci and the Dr. Fauci and the regular, institutions of public health.
I mean, I think so. If you look at Florida, there's been 4 waves of cases, including the summer wave. But if you do an age-adjusted death rate calculation from COVID alone, it's remarkably close to California. I think Florida comes out just a tad worse. They actually protected the old relative to California, even though Florida has a very old population. For instance, the 80+ group, there's the mortality rate from 80-year-olds and up is lower in Florida than in California. Same is true for 75 and same is true for 65. For the older populations, California did worse than Florida. For younger populations, it's remarkably close. I think Florida has slightly higher death rates than California with 4 different waves. And if you do a full age adjustment, you get almost identical death rates from Florida and California. So what did California's lockdown buy? And now you can't just look at COVID harms. You have to also look at lockdown harms. Florida had, next to, I think it was West Virginia, had the highest rate of children in school full time in the country. I think I actually participated as a legal expert in one of the cases where the Florida the union, the Florida Teachers Union, tried to shut the schools down after Governor DeSantis decided to open them last September, we won, and so Florida schools stayed open. By contrast, children in California skipped a year and a half of school. Again, just it's public school kids, not the private school kids. What was bought by that, other than enormous harm to the educational opportunities for children, especially poor children in California? Certainly not. I don't see any evidence that it actually reduced COVID death rates. You've had 3 waves in California. Will there be a 4th? I don't know. I'm actually not in the game of trying to predict the track of this disease. I think we've seen over and over how difficult it is to predict that. Did I expect there to be a summer wave? I did actually expect there to be another wave of cases in Florida. I anticipate there will be another one in the winter as well. It's a seasonal disease. Will it? What will be the effect? I think places that do well are ones that protect the vulnerable.
Yeah.
older populations. Places that do poorly don't protect the vulnerable.
Isn't the whole point of the IFR, which again, many of us are super optimistic and hopeful that the IFR results that were being demonstrated by groups like yours suggested very widespread infections, such that many, if not most, large population centers were somehow protected from disruptive waves, shall we say?
I mean, I think
right?
it's 2.8% was in April 2020. That is not sufficient population immunity to say we're not going to have this. I mean, when I got that number, I realized that we were in for a long epidemic. And we are. Now, there's a few things that are worth stressing here about the path of the epidemic. So first, people talk about herd immunity as the end point of the epidemic.
Right.
That's actually not right. This disease is, there's waning immunity over time, even for someone who's infected and recovered. It's actually wanes very slowly if you're infected and recovered. I think I'm seeing some estimates where only 0.3% of people who had the disease a year ago are reinfected within the context of full year. But you do see some waning in immunity over time. This disease, the herd immunity threshold shifts with the seasons. So in the winter, you need a larger fraction of population immune, very large, in order for the disease not to spread. In the summer, a smaller fraction of the population immune for the disease not to spread. Right, so there's a sort of sinusoidal property in the herd immunity threshold. So the disease is going to come back, as just like it does with the other coronaviruses. It's not any different in that sense. You get.
I'm glad you say that, because it's perhaps that was a nuance that was missing in the Great Barrier Reef Declaration. I'd have to go back, but you're right that herd immunity is sort of it's a bit of an elusive concept. I mean, it's not an empirical observable thing. You cannot go and say, the population is immune, or even one individual is immune. And so you have to think about it that it gets to the point where it becomes more acceptable and manageable, right? I mean, the infection rate becomes more manageable, which in a way, it's been like that, for a while, because if the initial rationale for the lockdowns was, protect the hospitals from being overwhelmed and whatnot, even Florida, right? I mean, Florida adopting or being inspired by your advice has never been overwhelmed, really.
No, I think there are places that have been overwhelmed, but in the United States, there's been very, very few examples of overwhelmed hospital systems. I mean, I think hospitals, of course, have been pressed. Right. Absolutely. Yeah. Some have been pushed very hard. But I think the system as a whole in the U.S. has not been over. I mean, I think in the U.K. there's been places where have been overwhelmed. Certainly in Canada, in Montreal, for instance. I mean, I think there have been some examples I think you can point to. I think the key thing though is if you look at the endpoint of this epidemic, it's sufficiently large number of people that have protection against the disease. Right? That doesn't mean the disease isn't going to come back. It will come back. It's just that when you're reinfected, it's much milder. And we're just, for people listening, you can't hide from this disease. You are going to meet SARS-CoV-2 at some point in your life, probably multiple times. Right. That's just a fact. Once you've accepted that fact, then all the rest of the policies you can understand why they're bunk. The vaccines are a fantastic tool, by the way, for this. I say that the infection fatality rate is 0.2, so maybe it's 0.3, 0.4. I don't know. It matters. What matters is who's infected. If older people tend to be infected, you'll have a higher infection fatality rate in a region. But with the vaccines, you can cut your probability of severe disease by a very sharp number, 90, 95%. The vaccines should have made us much less fearful of this disease, because we now finally have control over it. In fact, most places adopted the Great Barrier Reef Declaration strategy in rolling out the vaccines. They rolled it out of the old first, right? Right.
Right.
Which was the right strategy. In fact, I wrote an article in the Wall Street Journal in December of last year arguing for exactly that. It's like, this is the Great Barrington strategy. We find now we don't have to argue about, is focused protection possible? Oh, by the way, it was possible before, but we can talk about that later. But with the vaccines, that it's now becomes a theoretical thing, because now you have a perfect way to do focused protection. Vaccinate the old, vaccinate all the vulnerable people, and now you've cut the risk of the disease. In fact, you see this in the UK. They had a huge wave of cases in the spring and the summer, and the deaths are flat because they vaccinated the old very effectively. Same thing happened in Sweden. They only had 7% of the population vaccinated in March of this past year. They had a huge spring wave of cases in Sweden and very few deaths because every dose went to an old person.
Right.
That is what focused protection and the GBD. That's what success looks like. Not that the cases stop spreading, because that's impossible. We have no technology to stop the cases from spreading. What it looks like is a decoupling of cases from deaths.
Right. Did you see? Did you expect more of a decoupling from death in this final wave that hit Florida or not final? The fourth wave that hit Florida.
Yeah, I did actually expect more. I did expect more decoupling. That's absolutely right. I think part of the problem was that Florida had done quite a good job at vaccinating the old, but there were still maybe 15% of older population still was not vaccinated. That's true nationwide in the U.S. We actually have not done such a great job of vaccinating all the old.
Does that, if the endpoint is partly through vaccines, then in terms of the policy prescription that you have until you get to a safe vaccine, is it true? When you testified, just to be clear for the audience, you testified for Governor DeSantis's team in upholding their desire to allow parents to choose whether or not their kids should be masked or not. So, pushing back against mask mandates. And as part of that testimony and stuff, somebody put words in your mouth. And so I just wanted to, they said his theory is that natural herd immunity is the way to get out of this pandemic. And it doesn't take into account the human toll and loss of life, the morbidity and mortality that will result. Is that your plan prior to?
Both parts of that statement are false. I don't think that natural immunity of everybody is the way out of the pandemic, in the sense of, like, I think the right way out of the pandemic is focused protection of the vulnerable. The pandemic will end just as every pandemic will end. And as I said, I think no matter what we do, everyone's going to get infected at some point. Like, there is no technology we have to stop disease spread. Unless you hide forever, you are going to get infected. So at best, something like focused protection works to protect the old until you have some technology protect the old some other way, right? So I think that it's not right to say that I believe everyone should be infected. I'm just saying acknowledgement of the fact that we don't have a technology for stopping it. The other part of this, which is I think that we should hurt children, that is also false. I don't think there's any high quality evidence whatsoever that masks do anything to stop the spread of the disease in children. There are no randomized studies, that's for sure. And when you look at the non-randomized evidence, I don't see any difference between the masked up districts and the non-masked districts in places like Florida, for instance, or New York or wherever. I mean, you just don't see it's hard to look at the data and say, oh yeah, mask is the silver bullet. And what randomized data we have suggests a very small effect of masking, if anything, in adults, none in children. Before the epidemic, there were like a dozen or more randomized studies of flu spread and masking, and they found null results, high quality studies, even in places like hospitals. We have essentially told the public a lie. We've told them we have some technology to stop disease spread when we don't actually have such technology. Acknowledging that is not irresponsible. Acknowledging that is actually the responsible thing to do. So I think the question isn't whether I want to do.
Focus? Oh, sorry.
Oh, sorry. Go ahead.
No. Finish, please.
Oh yeah, I mean, I think the responsible thing is to tell the public, look, the vaccines are great, and get them, especially if you're vulnerable, as much as you can. Instead, what we've done is we've expended all our energy on a series of policies that are low yield, really not good evidence in favor of them, and pretended like they were going to work when they haven't. We've sapped all of the sort of like moral capital that public health might have on these low yield things that have been incredibly divisive. And as a result, we have a part of the population that doesn't trust public health anymore about the vaccines. It's really, really regrettable.
Yeah.
So
what does focus protection? Sorry, Michelle. One last thing. What does focus protection look like before there's a vaccine? Like, how do you go about protecting the elderly?
That's a really good question. And we tried to like address some of those some ideas that we had in the Great Barrington Declaration itself, ideas for focus protection. It really depends on the living arrangements of the older person. So, for instance, in nursing homes, here's a very simple idea: don't send COVID-infected patients back into a nursing home. That's a focus protection idea we really should have adopted in spring of 2020, for instance. That's a gimme. It's a chip shot, right? It's not that, but there are other things, right? So nursing homes, they have staff members who many of whom work in multiple nursing homes, and they track the disease through. Using testing, for instance, to like make sure that when they arrive, they're not positive. Actually, we could have even done something even more radical. Like we could, in the old days, medical residents used to live on the hospital. That's why they're called residents, right? We could have turned nursing home care into, if you work for a nursing home, you live there for a month at a time. You month off, month off, month on, month off, and for the whole month you just live in the nursing home. You don't come out. Right, reduce the amount of spread, like tracking in and out of the nursing home. Use in nursing homes, I think we're like 40% of the deaths. That we should have been much more proactive in protecting nursing homes with radical changes in how we provide the care there. That would have been a focus protection. So we suggested some of those in the Great Barrington Declaration. Another is like take older people living alone at home. We had a situation where we use online resources, DoorDash or whatnot, so that young urban or young professionals could get not be exposed, while older drivers are delivering the food to them. Why don't we flip that around? We spent trillions of dollars. Let's instead provide home delivery of groceries to older people, right? Instead of asking them to go get groceries and intermingle with other people who might have COVID. We could have, if we had decided to do focus protection, it would depend on the living circumstance. I mean, it's different in poor neighborhoods than in rich neighborhoods. If you have multi-generational homes, we used hotels to house the homeless, many of whom were young. Instead, or in addition, we could have used hotels, offered them to people living in multi-generational homes. If your grandkid comes home and says, "Oh, I might have been exposed to somebody, Grandma," then Grandma then gets offered a hotel room that night to stay while you check to see if the grandkid actually got sick or not. Right? I think we could have used, there's lots and lots of ideas we could have had that are specific to the communities at large. That's normally what public health excels at, is using creative ways in the context of the communities where they work to try to protect vulnerable people. The stunning thing to me was that instead of meeting this challenge with this proposal, with the Great Barrington Declaration of Focus Protection, saying, okay, yeah, how can we implement it? They all just uniformly said it's not possible. I was floored, right?
Well,
I've never.
Right. But, I mean, Jay, what you propose, I think makes a lot of sense, but it makes a lot of sense so long as it is voluntary, providing resources, providing advice. Public health, I mean, the way I view it, I mean, it's nothing new. Public health is mandates, quarantines, do this. I mean, it's always, I mean, the history of public health is sort of like that. I mean, I don't think public health has ever been sort of this, it's a TB, directly observed therapy, right? So it's almost, it's an arm of the police force, if you will, focused on health. And so the people who work in public health, I mean, I think their frame of mind is, what can we do that is coercive? And to do what the Great Barrington Declaration suggests in a coercive way, because you could interpret it in a coercive way. You could say, older people, we're going to separate the olds from the young. We're gonna force the old not to go to the grocery store. They're going to be locked into their homes, right? And that, I would say, I think would be obviously very difficult to implement. So in a way, it may be just a difference in a very fundamental way of thinking about public health.
Yeah, I think, Michelle, I think you raise a good point, right? So I think there's two frames of thinking in public health. There's the frame of thinking of resources, empowering people. Like the Swedish Public Health Agency, that's exactly what they did. I mean, they made some mistakes early sending infected people into Stockholm nursing homes, right? But for the most part, they built trust with the population, provided them good guidance about what's risky, what's not risky, and that kind of public health, that sort of like public health where it's public health in cooperation with the public, in my view, has always been what's attracted me to public health. That's the philosophy of the Great Barrington Declaration. We do not have any coercive ideas in it. I don't think. If there is, it wasn't by my intention, right? In fact, I'm pretty sure there isn't.
Right.
Whereas this other idea of authoritarian public health is almost guaranteed to build distrust in the public. In fact, not almost. It's guaranteed. It's built distrust in the public, and ultimately, is going to be much less effective. Like you may. For instance, the vaccine mandates is a good example of this. You may, through coercion, increase vaccine uptake levels for this vaccine, but many people who feel coerced are going to wonder about the child vaccinations that they're going to do when they have kids, right? Because if you don't have that trust, public health cannot work. And public health has done absolutely everything it can, certainly in the United States, to undermine that trust by the public.
So why is that? I mean, I think your view, which I share greatly, is a tiny minority view in public health, as far as I can tell. You're still not right. I mean, I don't see colleagues embracing you.
I don't know about that. I mean, I think the authoritarians are in charge, but I don't know if we're the minority.
Okay. Right.
I think actually most people in public health, most doctors, most even scientists agree with this idea. Just take the Great Barrington Declaration itself. Hundreds of thousands of regular people signed on, tens of thousands of doctors and scientists signed on. And this was despite enormous suppression by big tech and essentially propagandizing by people like Tony Fauci about it, who called it a let it rip strategy, when you can hear, obviously, I'm not interested in letting the virus rip. So I actually think it's a majority view. What's happened in this pandemic is that the people who are in charge of public health have done everything they can to make sure to marginalize everybody else. And so essentially like the kind of like actions they've taken have made people afraid, prominent people even afraid to speak up against the kinds of policies adopted. Some of the people that signed the Great Barrington Declaration, they email me and tell me they lost their jobs over it.
Right.
I've had lots and lots of people write to me saying, I wish I could sign it, but I'm afraid for my career. I think it's not healthy to have a situation where people who are qualified, scientists, are afraid to say their views. And that's essentially where we landed.
It's remarkable because, I mean, this didn't happen just with COVID. It must have been there, before. I mean, that's sort of that mentality, that coercive authoritarian mentality. I mean, is it a phenomenon that what Hayek described in The Road to Serfdom, essentially that, certain things attract certain types of personalities or certain worldviews?
Okay, so let's try to give the most positive
charitable,
possible.
Right? Yeah.
Let's try to do that. So I think if you take the norms of public health, the norms of public health involve in part this idea that if you give a confusing message to the public, then the public won't listen to you, right? When public health messaging comes out about the harms of smoking, for instance, the norm is that someone shouldn't be saying smoking is good for you. First, that's wrong. Smoking is terrible for you. And then by casting doubt about it, you've undermined the effectiveness of the message. So there's this norm of unanimity in public health that's actually quite strong, right? But now, on the other hand,
when you say there's a norm, are you saying that that's sort of it's a wish by the community, or is it?
Yeah.
Okay.
Because there's a norm in public health messaging that you shouldn't be you shouldn't be like casting doubt on the clear messages that put out by public health. If you are, you're doing something wrong. That's what I mean by norm.
Okay.
On the other hand, science needs to have people questioning. It has to have it all the time. If you believe A, I believe B, we're going to argue with each other, and we'll come up with an experiment. And it turns out that A is right, and then I buy you dinner, and then we go. Then I'll have it. Oh no, well now it's A prime, and we keep going, right? That you have to have this dialectical process of people disagreeing with other people, looking at evidence, coming to some conclusion, and then just that process keeps going on. Science does not, it has a norm, very strong norm of entirely open discussion, or else it's not science.
Right.
The ethical basis for the public health norm of unanimity of messaging is that science has done. It's found a fact that most people, the vast majority of scientists, when you're disagreeing, are disagreeing on some marginal issue, not the central point. And so the public health message, the central point is essentially repeating back what the scientists have come to. But here we have a situation where the science hasn't come to a conclusion about lockdowns effectiveness, about masks in children effectiveness, about focus protection, about the IFR. It's all open. And yet somehow we arrived in the situation where the norm of unanimity in public health messaging was enforced from the very beginning of the epidemic. It's a huge error. What should have happened was the uncertainty about all these things should have been conveyed to the public. That would have been the responsible thing to do for public health to do. We're still seeing it, right? If you speak up about masks in schools, I mean, I pointed out as I said, I pointed out that there are no randomized trials that establish that masks in schools do anything.
Right.
None, literally zero. Just for saying that, I was banned off of YouTube in a public discussion with the governor of the state of Florida. I mean, think about that. Like the governor is providing his, like, to the public, access to the scientists that are advising him in a public discussion. That's good government, right? And yet YouTube bans that.
Yeah, but so I mean, I can see why you're trying to put it charitably by saying that it's a conceptual error to imagine that the science is settled when it is not, but it's obvious that it's not. I mean, these people are not stupid. So I mean, I think we have to consider the less charitable, possibility that there's this streak of coerciveness, authoritarianism among academics, among public health people. And, I mean, you see that the perfect correlation between the support for vaccine mandates, for mask mandates, for lockdowns. I mean, they all go
driven
hand in hand.
by fear. It's driven by fear, right? So one of the parents that testified on the other side in this Florida, when you testified, was a mother of twins that said their classroom lacks social distancing or plexiglass barriers to virus transmission. The kids, she said, are literally on top of each other. The school is a petri dish right now. And again, obviously, there should be nothing settled about plexiglass stopping virus transmission, right? or if you put whatever whatever you want to do to kids to, like, I don't know, if you put them in little little cocoons while they're playing their music, trumpets, or whatever people want to do. None of that is. But you can see what's imbued. I shouldn't be making fun of it. But my point was my point was that there's a lot of there's so much fear that you can almost, that comes out of the words from that mother.
Yeah. But that's I don't blame her.
So you really have very, very, very different. Yeah. Right. No. Exactly right. So I'm not blaming either. But it comes from these very, very different priors, right? There's a prior that you have that says, look, this isn't settled. I'm not sure this is as bad as it's being advertised. Look at these IFRs. And then there's the other prior that is, oh my God, MISC, long COVID. If it gets in, the IFR doesn't matter because the numerator was what matters, right? If you can get a large metro area to have trucks lined out with morgues and hospitals running out of oxygen, or what happened in New York, if that is possible in any metro area in the United States, then that mandates everything, and everything that we can possibly do, whether we know it works or not. So
I mean, that's just that last point that's hard. Like, actually,
yeah.
I take exception to both those points, right? So one is we shouldn't do anything we possibly can do if it doesn't work,
Right.
because the reason is simple. Like, those activities have harm, right? Putting kids in little cocoons harms them. That's why we don't normally do that. And unless there's evidence that it actually is necessary in terms of producing good results, then it's not responsible to do it. We are in medicine, we never do something without good evidence in favor of doing that thing. And yet medicine has adopted all kinds of things with no good evidence behind it during this pandemic.
Right.
I think it's utterly irresponsible. Like I don't blame that mom. I mean, she's been bathed in fear rhetoric from experts who should know better.
Correct, and we know that they know better.
But the experts,
they know better because from their behavior. I mean, Neil Ferguson, the guy behind the Imperial College model, was caught, violating all the lockdown rules.
I don't think that lockdown rule specifically is explicit.
Right. No, but I mean, certainly, I mean, a lot of people, I mean, they're not all, I mean, people in position of authority who are imposing mandates and whatnot, many of them, some of them are politicians, some of them are public health people. I think it's clear that they don't fear necessarily for themselves. I think there's a streak of authoritarianism, and then it's opportunistic, and then it uses fear.
But Michelle, have you seen these these are absolutely shocking to me. These polls of epidemiologists' comfort with risk.
Oh, so, right.
I mean, it's like they're essentially they're essentially neurotic. Like
they're still not opening their mail, right? Some of them, I think 20 or 30% refuse to open their mail.
I think like, I do not want these people in charge of my life, and I think most people would agree with that. And yet they have been the experts that the press will go to, even though I think the vast majority of people, including epidemiologists, don't actually agree with that in their own lives. I think you're right. It's just a very particular set of people with hypochondria issues, I guess, that have been like referred to by huge numbers of journalists who actually also, I think, have these sort of hypochondria issues. I mean, they end up.
How come there's no counterbalancing voices? I mean, if
there are, but they're silenced. Like, look, you know how much nastiness I've faced. I mean, it's really difficult to speak up in this environment if you don't agree.
Right.
I'm sure. I mean, you two must have faced some of it as well, I imagine.
We're too insignificant to. It's right, but still, I mean, supposedly academia, but I mean, I think it goes hand in hand with the stifling of ideological diversity that we see in academia across a broad, spectrum of issues, not just public health, but.
This is a beautiful segue into this idea, like, in terms of the culture in academia now. Do you think it's significantly worse? That seems to be true, given what you've faced. I mean, you've faced a tremendous amount of pushback, even at your institution, right? Yeah, colleagues of yours have written letters. They've accused you of being. They want Stanford to take some type of sanction against you, etc.
It's a strange thing. Like, I've been at Stanford for 35 years, first as a student and then as a professor for the last 20 some years. I've never seen an environment more closed to free discussion in my entire life at Stanford. I mean, it's normal. I mean, there's lots of contentious issues that we talk about and that's just normal in public health and in health and health policy and health economics. But I'll tell you, like, in December of last year, the old president of the university, the ex-president, John Hennessy, tried to organize a debate between me and someone who takes a different view than me at Stanford. And he couldn't find anyone to agree to debate me. I was stunned by that. Like I'd already had debates with Mark Lipsitch, organized by JAMA. I'd had that like very nice exchange with some folks at Johns Hopkins. I wouldn't call it a debate. It was a nice discussion, actually. I've had a Monk debate with Stan Berman at Yale. I mean, I had a series of debates already. And yet at Stanford, they couldn't organize a debate. What's happened instead is like essentially demonization and marginalization of alternate views, essentially trying to silence people who disagree by mass petition, mob petitions. This happened like in particular to Scott Atlas. A whole bunch of my colleagues signed a letter where they said things that he didn't even believe. Like they said that he was against hand washing. That's just a lie. He's not against hand washing. And yet they put this letter out to the press in order to silence him and to shame him.
Right.
And many people that signed that letter, it was organized by the former dean of the medical school at Stanford. Many junior people signed it because they felt pressured to sign it. You've created this situation where the one place where there should be open discussion, instead you have this sort of like mob of people trying to silence anyone who disagrees. Instead of like an invitation to open discussion, it's the norm, that strange norm of unanimity messaging. They feel like somehow Stanford has violated it, and so it's okay to violate the key thing about a university, which is free and open discussion of ideas.
So Jay, the last few minutes that we have, I want to go back to this idea that you talk about of trade-offs and the importance of taking into account trade-offs. And if I may, I'm going to actually turn it around. And I think maybe the problem is actually in the idea that it's a matter of taking into account, right, balancing the pluses and the minuses. Because if you view it that way, in a purely utilitarian way, you say, okay, maybe older people are going to be killed, maybe kids, we have to weigh in. At the end of the day, somebody has to make a decision. I mean, there's no calculus really. You cannot balance, right, an older person dying, a kid wearing a mask, the psychological harms that's going to happen, maybe over 10 years. What's going to happen in the third world? You talk a lot about third world countries, and I wish we had more time to talk about that, because I think it's a real issue that is completely off our radar. But at the end of the day, yes, take an opponent to your view may agree with them and say, yes, there are trade-offs. You have a certain preference for what kind of balance of outcomes you want, and I have mine. And at the end of the day, I'm in charge, and it's going to go the way that I want. And I think implicitly, I think that's the way it is, because none of these people deny the trade-offs. I mean, they will say, yes, there may be harms, but we have to do it, which means that they agree there are trade-offs, but they think that their view of seeing things is the better one. And therefore, I think it's a crisis of just fundamental values that are clashing and that are not expressed, because we're sort of hiding behind this, quasi-scientific way of trying to settle the matter. I don't know if I expressed myself.
No,
well.
I think you've hit on exactly the right issue, Michelle. So the key thing is, who gets to decide these difficult trade-offs, right? So normally we have a political process that does that. That political process, in effect, what happened was that many governors and political leaders gave that decision-making authority to scientists who are not in any position to make those trade-offs. Mm-hmm. Actually, let me just say one thing about the trade-offs themselves. I think the Great Barrington Declaration is a Pareto improvement. It improves the lives of both the old and the young, because the old are protected by these focus protection ideas much more than the lockdowns protected them. The young, because they don't face the lockdown harms, they're also better off. So
I disagree, because you're discounting the psychological well-being of people who are fearful and hypochondriacs, right? Why should you discount the hypochondria of the hypochondriacs? Okay,
all right, you got me. I mean, I think you're right. I mean, I think that's you're right. There is a group of people, and I said it already, who benefited from the lockdowns. Should that group of people really have control over the policy that has harmed the lives of hundreds of millions of people worldwide? I don't think that's right. And I think most people agree with me that it's not right. Democratic processes that look at this rationally would also agree it's not right. We've essentially taken the health policy and put it in service of the laptop class. It's trickle down epidemiology is what this is. And if you frame it that way, which I think is the correct framing, I don't think it survives democratic governance. So I think the trade-offs that you're right. Every policy has some trade-offs. Those trade-offs are navigated by a political process that hopefully has some democratic legitimacy. If you offload those trade-offs to scientists and say, well, look, what does the science say about these trade-offs? The answer is science says nothing about who we should elevate, who should we not elevate, right? Those are moral issues that we all may differ on, but we negotiated in a political process. Science can say, if I do a lockdown, this is the class of people that will be protected. These are the class of people that will be harmed. Science can say, here's who's really at risk from COVID. What you do with those facts about in terms of policy is a completely different thing that involves much more than just science, but fundamental values that each of us have about where the scarce resources of society ought to be devoted.
Right, but I don't know, because it seems that politicians always and before COVID delegate to technocrats essentially.
Yeah,
these difficult decisions, or they hide behind sort of technocratic.
Yeah, I mean, if the science says to do this, I'm just following the science. I mean, right. It's a very, very easy way to offload responsibility for something that they actually have.
Right.
Scientists should say, no, thank you. I'm not interested in telling you what to do, but here's how the trade-offs are. Then you make the decisions. I mean, I think that this is one of the things I've been very impressed with about Governor DeSantis. Like he understood actually the trade-offs. I mean, from talking with him, it's really clear he knows a lot about this literature, the scientific literature around this. And he made some decisions about those trade-offs. Mm-hmm. I think they've come out really well, but if they came out poorly, and maybe someone thinks they came out poorly, he's going to face the consequences of the voters, right? I think the thing is, what I tell politicians is you can't avoid that. You're going to face the consequences of voters, even if you think that you're offloading it to the epidemiologist decision. You're not ever going to escape that. You have to make those decisions. So it behooves you as a politician to go seek out a very wide range of scientists so you can understand sort of how confident you can really be in the decision you're making, because you can't escape.
Right. What's next for Jay? So you find occasionally an audience among decision makers who can listen to you. Are you trying to convince more of them?
I would love everyone to agree with. I mean, obviously, no. I think these lockdowns are the lockdowns that we instituted last year are likely not to come back. I think we've won that argument. What's now remaining are the arguments over vaccine mandates and mask mandates and whatnot. Even those are going to end. I don't think this is permanent. What has been damaged is the possibility for free scientific discussion. And I don't know how science recovers from that without a lot of soul searching. So I would like to work in the years ahead on trying to repair that damage. Same thing in public health. I think public health, it needs to apologize for what it's done to the public. And so I'm going to work to try to reform public health. My personal future, I don't know. I always thought I knew exactly what my life was going to be like. And I did until just a year and a half ago. And I never would have anticipated finding myself in the midst of this. So the future is still, in that sense, still dark, but I would love to continue to be involved in health policy, which I've trained my entire life for.
Jay, Dr. Bhattacharya, you've been a beacon of light in this dark pandemic. You and some, I mean, you're not the only one, but we're very grateful for a voice in academia that makes sense. I mean, we're not asking for more, just a little common sense and good insights. Anish, do you have anything else to say before we close?
No, I was going to just reiterate that the courage it must have taken to do that when it was far easier to stay silent, is much appreciated. So and I think a lot of folks recognize that. And I say that because you recently came on Twitter. You finally arrived on Twitter, I think a few weeks ago. His handle is Dr. J Bhattacharya. We'll have it on the show notes. And already in 2 or 3 weeks, you have 57,000 followers. So I think you have a lot of folks that are.
Talk about courage. I was scared of Twitter for a long time, so that actually did take a little courage to go on there. But it's been interesting and fun, and I've learned a ton from it. I think it shouldn't take courage for scientists to speak up with their views. Let's work toward a scientific community where where really shouldn't that courage is not needed.
Jay, thank you for joining us.
Great final point.
Thank you. You take care.